Hi everybody, it's Dr. A. We're going to look at pancreatic diseases as part of Clinical Chemistry 1, and within this chapter we're also going to look at diabetes, obviously as a pancreatic disease. So let's get started. Okay, so a quick overview of the pancreas. It is located below the stomach, above the transverse colon, right here. It is composed both of endocrine and exocrine tissue, although the bulk of the pancreas is going to be exocrine tissue. The exocrine cells, also known as the acinar cells or Cini cells, are essential for digestion because they're the ones who produces all the digestive enzymes and that really rich bicarb fluid that neutralizes the stomach acid. And the endocrine cells, though, are what we're interested in also here with the diabetes is they are the alpha and the beta cells. The beta cells are located and also often called the islets of Langerhans or the beta cells of Langerhans. But they are producing insulin. That's their main job, and that's why it's tied to diabetes. The alpha cells produce glucagon, and these little islets of Langerhans so containing those beta and alpha cells are dotted throughout the pancreas, but again, they're not part of the bulk of the pancreas. Again, as a review, insulin will reduce the amount of glucose in the blood, and glucagon will increase the amount of glucose in the blood. And so together, insulin and glucagon strive to keep the blood sugar at a normal level. And so, quick one, which of these lowers glucose? And so just think about it, high glucose, and it lowers it, okay? Is it insulin or glucagon? If you're not sure, go back and think about it for a second. Okay, we're going to start first with pancreatitis. So it is an inflammation of the pancreas. And what happens is the digestive enzymes are actually causing a destruction of the pancreas. And normally, in a normal functioning pancreas, when everything goes well, those digestive enzymes are made as zymogens, which are inactive, and when they're released and when they hit the duodenum and get mixed with the food, then they get activated. And so that's what normally happens. But when you have pancreatitis, then these enzymes are getting activated inside the pancreas, and the problem is it does what these enzymes are made to do. So these digestive enzymes are made to break down protein, fat, and carbs. And what are your cells made of? Well, lots of fat and some protein and some carbs. And so they're really good at destroying cells also. And what happens oftentimes is that there is something that causes the blockage. So stones are pretty common, and it causes the blockage of the digestive juices, and so that causes them then to react and to activate in the pancreas itself instead of inside the duodenum where it's supposed to activate. And so acute pancreatitis often just resolves itself, but chronic pancreatitis doesn't, just stays, and it's usually the result of long-standing damage to the pancreas, and a patient usually has to live with it for the rest of their life. So let's start with acute pancreatitis. It can be life-threatening because it can cause hemorrhage. And so you can get a lot of bleeding in the GI and abdominal area. The common causes of acute pancreatitis are going to be gallstones, but also heavy alcohol use. Symptoms of acute pancreatitis are going to be severe abdominal pain, fever, nausea, and vomiting. And the diagnosis is done with serum amylase and lipase levels, which are going to be greatly elevated. Lipase is more specific to acute pancreatitis because you also have salivary amylase, so other things can raise amylase levels. But I mean, how many cases of mumps do we see? I mean, it's possible, but generally speaking, when you see high amylase and high lipase together, you can suspect acute pancreatitis. So chronic pancreatitis progresses over time and leads to permanent damage. The most common cause of chronic pancreatitis is going to be persistent and heavy alcohol use. And that can result both in diabetes and pancreatic insufficiency. And we're going to cover diabetes. It would be a type 2 diabetes that it would cause here in just a minute. So how do we diagnose chronic pancreatitis? Well, this one's a little bit harder. So the blood tests are not as helpful as in acute pancreatitis because the amylase and lipase results can often be normal. Trypsin levels are relatively specific, but they don't show decreased levels until the disease is really advanced, so not very helpful there. There are a few functional tests that can be done. The secretin test is sensitive, but it is an invasive test because they have to be intubated with a tube all the way down into the duodenum. And it's performed at specialized institutions only, so again, not widely available. There's also testing available that requires a patient to take an oral dose of something that can be broken down by the pancreas that's tagged in some way or another, and then that substance is then measured in the serum or urine. Again, a little bit more problematic, but just saying there's just not a lot of blood tests to help with the diagnosis of chronic pancreatitis. So moving on to diabetes, we're going to spend a lot more time here in diabetes. So diabetes is a result of the malfunction of the endocrine part of the pancreas. The two types of diabetes you'll see are type 1 and type 2, and we're going to get into detail in each one. But basically type 1 used to be called, or can be still called, insulin-dependent diabetes. It was called juvenile diabetes, and it is an autoimmune disease, or it's an autoimmune reaction to the beta cells. And so you have total destruction of the beta cells and total lack of insulin in type 1 diabetes. And then we have type 2. It's non-insulin dependent diabetes mellitus, was called adult onset diabetes, and it is lifestyle mediated. And so we moved away from juvenile and adult onset terminology because with the current lifestyle that we have in the U.S., we are seeing more and more type 2 diabetic patients that are children and adolescents. And it is also possible for adults to get type 1 diabetes as adults. Although it is rare, it usually happens in childhood, it is possible for adults to get it also. So let's take a quick look at a case. So John is 19, he's a college student, he has flu symptoms, he goes to the ER, he has headache, muscle aches, and fatigue. It just doesn't feel right. And they draw some labs, and lo and behold, his glucose is 800 milligrams per DL. Now, it should be below 100, so this is greatly elevated. His sodium is 120. It should be above 135, so that's really low. His potassium is actually dangerously low. His potassium is 2.9. It's too low. Chloride's 92. All of that's too low. These electrolytes do indicate dehydration. And then he has acetone or ketone at a 3+. So what is the likely diagnosis? So which one do you think he has, type 1 or type 2 diabetes, and what is the cause of the disease? So what do you think he has, type 1 or type 2? And there is something here that they both diabetes would have higher blood glucose levels. And so then you have, how do you distinguish the one between, from the other? And the hallmark is going to be the presence of acetone or ketones, and that is actually more typical of type 1. So again, as mentioned earlier, what is the cause of type 1 diabetes? And so type 1 diabetes is an autoimmune reaction or autoimmune disease. Okay, so let's just dive deeper into type 1 diabetes first. So with the autoimmune reaction, you have antibodies that are created, and you get a beta cell destruction in the islets of Langerhans. It usually happens in childhood. And what the trigger is, they're not 100% sure, but we think it's a viral disease of some sort. And then there's some molecular mimicry, something that happens, and the immune system gets carried away, and it mistakes the beta cells for viruses and destroys them. So because the beta cells are destroyed, you get a total insulin deficiency. The insulin production is completely cut. Insulin is a hypoglycemic agent, meaning it lowers blood sugar, not meaning it kicks in when you have hypoglycemia, okay? So it's the opposite of it. So it lowers high blood sugar back down to normal. So its major effect is to promote the transport of sugar across the cell membrane of fat in muscle cells. And so it's often been referred to as the key. So on the surface of your cells, you have insulin receptors, and insulin has to dock on the insulin receptor. And when that happens, there's a portal that opens that only allows glucose in. So it's a glucose transporter, basically pops up on the surface of the cell and accepts the amount of glucose that it needs into the cell. And this is part of the normal mechanism. And so with no insulin present, there's no insulin to dock on the receptor, and therefore there's no glucose transporter that are carried up to the surface of the cells, and so glucose does not get inside the cells. There's plenty of glucose outside the cell, but it's just not getting inside the cell. The autoantibodies are going to be T-cell mediated destruction of beta cells is basically what's going to happen. So it's really a cytotoxic reaction. If you get into the immunology, you just need to at least know it's an autoimmune reaction where your own body is, or the patient's own body is destroying the beta cells there of the pancreas. So the symptoms are going to be quite similar to those of type 2 diabetes. We have polyuria, so excessive urination, polyphagia, excessive hunger, polydipsia, excessive thirst, weight loss. So this is a hallmark of type 1. You have weight loss and fatigue. So the absence of insulin, because it's not there, it results in excess of glucagon. And why is that? Why would you make glucagon? Because glucagon is supposed to raise a low blood sugar back up to normal, and you have a high blood sugar. Why would you get glucagon? And the reason is the cells aren't getting the glucose inside, and so the cells are basically sending the signal that they're starving and we need glucose, and so the body is responding to that by making glucagon. Even though there's a lot of glucose, just none of it's getting inside the cells. So the glucose is stuck in the bloodstream, so the cells have to produce ATP, and so they're going to do lipolysis, so they're going to break down fat to produce ATP. And that's going to generate ketone production inside the cells. And so those ketones are going to be evidenced as ketones or acetone, depending on how you test for it. The glucagon that's present leads to excess gluconeogenesis. So not only do we have an abundance of glucose already in the bloodstream, the liver is going to start converting non-carb sources to glucose, and it further increased this glucose because the cells are starving, because the cells aren't getting the glucose. Insulin also stimulates lipogenesis and inhibits lipolysis. So this insulin, normally, this is what it normally does. So insulin, think of it as a storage hormone and an energy use hormone. So one, it gets glucose in the cell so that they can be used to make energy. And two, once all the cells are replete, then insulin is going to store the excess energy, usually as fat. So insulin is also a storage hormone. So that would be lipogenesis, storing excess energy as fat, and it blocks lipolysis. It blocks the breaking down of fats because it's a storage hormone, okay? And so in type 1 diabetes, there is no insulin. Insulin is not there, and so the lack of it leads to weight loss because it's going to do lipolysis, because it's no longer, insulin normally inhibits lipolysis, it's no longer present, therefore the fat cells are going to break down and release their fat content so that can be burned for ATP also, and then so that's going to lead to the weight loss. And because the patient is going to be burning fat as fuel, there will be the production of ketones, and that can lead to diabetic ketoacidosis. We're going to talk about that here in a few slides. Okay, so now let's go over what happens in type 2 diabetes, which is different. So type 2 diabetes is actually a spectrum of disorders. It starts with insulin resistance, and which is basically impaired insulin action. So in insulin resistance, you have insulin that's being produced, and you have the receptors for insulin on the surface of the cells, but somehow the receptors aren't receiving the insulin, they're not responding to it, and so the glucose transporters, there's not enough of them being put up, and so you get what they call insulin resistance. Then it can progress to a relative insulin deficiency, meaning because of the insulin resistance, the body will respond by simply producing more insulin to try to get an effect from the cells so that the glucose gets transported inside the cells. And so there's going to be, there's basically, even though it produces more, there's not enough to allow enough glucose inside the cells. And then it'll progress to where then the pancreas kind of just wears out because it's been trying to crank out insulin at a greater rate to the point where the cells just basically are taxed out. They're done. And so then you start seeing beta cell dysfunction where the insulin levels now, instead of being high, which that's the big difference between type 1 and type 2 diabetes, is in type 2, you start out with high insulin levels and then towards the end it can drop, whereas with type 1 diabetes, from the get-go, they have no insulin. There's no insulin being produced. The risk factors that puts a patient more at risk for developing type 2 diabetes are going to be abdominal obesity, so lots of weight around the abdomen, a sedentary lifestyle, so a lot of sitting, computer desks, computer jobs, and we have a lot of that now. Hypertension, so it's high blood pressure, elevated triglycerides and low HDL levels, which all of those together are hallmarks of metabolic syndrome. So having metabolic syndrome puts you more at risk of having type 2 diabetes for a patient. The symptoms of type 2 diabetes are going to be obesity. Remember, type 1 was weight loss, so there's a difference there. There's going to be some dyslipidemia, so again, high triglycerides, high cholesterol, low HDLs. Hyperinsulinemia, which is another big difference from type 1, because type 1 is no insulin, this one's high insulin. Hypertension, fatigue, itching, recurrent infections, visual changes, numbness, tingling, and weakness. Type 2 diabetes mellitus are going to be 90% of your cases of diabetes in the population. So usually if you see a patient and they're adults and they're overweight, you can pretty much bet it's going to be type 2 diabetes. But again, there are some adult patients with type 1 diabetes, and there are some children with type 2 diabetes. So they do not get ketoacidosis because even though there's impaired insulin action, enough glucose does get into the cells to block ketoacidosis, and so that just doesn't happen. But one of the complications they can get is hyperglycemic, hyperosmolar, nonketotic syndrome. So it's going to be a high blood glucose, hyperosmolar, very concentrated blood, but no ketones present. We're going to talk about that as a complication in a little bit. All right, so let's look a little bit. This is having to do with type 2 diabetes and risk factors. So we know there's a genetic predisposition in there. Also, the environment that a person is in also has an influence, meaning diet, lifestyle, all play into it. But there is genetic predisposition in there too. And so you combine genetic predisposition, especially with diet and inactivity, and you can first get obesity. And then obesity is going to lead to release of adipokines. There's an increased free fatty acids are floating around in the blood. There's more inflammatory cytokines and a decreased activity of ghrelin. So these are basically, obesity is like an inflammatory condition, if you will. And they're hungry all the time because of that decreased activity of ghrelin. And so that can result in more eating or overeating. And so this is going to lead to insulin resistance and causing the glucose to be backing up into the blood and not being able to adequately enter the cells, or the insulin is just simply not, the insulin receptor is not responding to the insulin that's present. So the body's going to respond by increasing the demand for insulin synthesis. So let's just throw more insulin at it and hope that the cells respond. So you get hyperinsulinemia, high insulin levels at first, and then you see some tissue effects of the high insulin levels without seeing hyperglycemia at first. So it's insulin resistance without diabetes. This is kind of the first part where it happens. And so these patients are often what we call pre-diabetic. So they can have normal blood glucose and high insulin levels, or maybe their blood glucose is slightly high but not high enough to be diabetic, and they have high insulin levels. So again, having those high insulin levels means that a patient is on that pathway to become type 2 diabetic. Over time, then, this insulin resistance, the obesity, and the increased demand for insulin synthesis and the genetic predisposition all at one will decrease the beta cell mass and their function. So the beta cells are starting to peter out. You also in here get a decreased activity of the incretins. And so incretins are released with insulin, and they basically determine how much insulin needs to be secreted for the amount of glucose that is present. So their activity starts going down because the beta cell mass is also going down. So they're related. Incretin and insulin is activity related. And so then at this point in time, you get low insulin. You have hypoinsulinemia. You also get a decrease in amylin, and amylin is secreted along with insulin, and it's supposed to give you a signal of satiety. It also inhibits glucagon, and so the fact that it's decreased, then you are going to get an increase in glucagon, and they're going to be hungry a lot too because that satiety factor is gone from the food. So there, at that point in time, then you can start getting tissue effects and hyperglycemia, which is then what you see with type 2 diabetics. So this slide is really helpful. So we're going to go around all the things here that causes this chronic hyperglycemia and diabetes. So first, in the pancreas, you have the decreased beta cell insulin and amylin secretion. Again, the amylin's needed for satiety and inhibits glucagon. And so since there's not enough of that being produced, you're going to get increased alpha cell glucagon secretion in the pancreas. And so that's going to lead to chronic hyperglycemia. So not only is glucagon raising the sugar, but there's not enough insulin here. There's some, it's just not enough, and there's not good response of the insulin receptor to the insulin. So again, sugar is backing up into the blood. And the fat and adipose tissue. There's a decreased insulin-dependent glucose uptake going on, so glucose is not getting into the cells, which then causes the cells to increase lipolysis, so they're going to break down fats and release them into the bloodstream. They are going to decrease also adiponectin, which is a hormone produced by adipose tissue, and it's normally anti-inflammatory. And it also helps to regulate the glucose and lipid metabolism in the fat cells, and it does influence the fat cells' response to insulin. And so this guy is going to be decreased. We need this guy to be up. All right. You're also going to have increased leptin and resistance. So leptin is a signaling hormone that signals your brain how much fat you have on your body and how much you can afford to get rid of. And instantly, you can also develop leptin resistance, where basically your body thinks that you have no fat and you can't afford to get rid of any fat, but you're indeed actually 100-pound overweight, for example. So that's what you would have with leptin resistance. And then there's also increased resistin, and resistin resists insulin action, so that's blocking the insulin action. And so you get also macrophage accumulation in the fat cells, which increases inflammation. So all that leads to chronic hyperglycemia. The liver, because of the increased glucagon, is going to have increased hepatic gluconeogenesis. So their liver is contributing to the high blood glucose here. In the digestive system, these decreased GLP-1, GIP, and decreased stomach secretion of ghrelin basically is going to cause them to patients to be more hungry and to eat more. In the kidneys, because the kidney cells, just like all the other cells, are having trouble getting enough glucose in there, they are going to increase the glucose reabsorption and also do gluconeogenesis. In the muscle, there's going to be decreased insulin sensitivity, so that decreases the glucose uptake. So it's harder for the muscle to take up the glucose to make ATP, to make energy, and that's part of why you see fatigue in these patients. And there will be an increased lipid accumulation around the muscles too. And then in the brain, there's neurotransmitter dysfunction, altered insulin signaling, and altered lipid sensing with the leptin resistance, etc. All of that leads to chronic hyperglycemia. So the consequences of having all of these are going to be retinopathy and cataracts, neuropathy, hypertension, peripheral vascular disease and stroke, heart disease, steatohepatitis, which is fatty liver disease, and biliary diseases like gallstones and stuff. Gastroparesis, meaning food is also not moving through the GI system adequately. It's staying behind, fermenting, and doing all kinds of icky stuff. Nephropathy with glomerulosclerosis, so damage of the glomeruli, and chronic kidney disease. There'll be oxidative stress, immunosuppression, infection, and cancer in the blood. There's decreased cognitions linked to Alzheimer's disease, etc. So this is a very interesting look at everything that's going on with type 2 diabetes. So how do we diagnose diabetes? So the diagnostic criteria are going to be the same for type 1 and type 2. You want a fasting glucose above 126 milligrams per DL, probably the easiest test to do. So if you can get a patient that comes in fasting, or have them come in the next day for blood work and come in fasting, if their blood sugar is above 126, bam, there we go. It's a diagnostic criteria for diabetes. If they have symptoms of polyuria, polydipsia, polyphagia, and an unexplained weight loss with type 1 diabetes, or they're overweight for type 2 diabetes, and a random glucose that is above 200 milligrams per DL. So this is a non-fasting glucose. They're in the physician's office and they go ahead and do a blood sugar and it's above 200, then you can bet they're diabetic. You can do 2-hour glucose, so that would be a glucose that is drawn post a load of glucose, or post, maybe you could possibly do a 2-hour postprandial also, but anyway, so you have a known intake of glucose and 2 hours later their glucose is still above 200. It should be back down to normal, or at least below 140 if the patient is normal. If it's above 200, that's another criteria that can be used to diagnose diabetes. If their hemoglobin A1C is greater than 6.5%, then they're diabetic. And then if the physician needs to distinguish between type 1 and type 2, if they suspect maybe this patient has type 1 diabetic, you can do autoantibody levels for type 1, antibodies to islet cells, anti-GAD65 and anti-insulin antibodies can be done. And obviously you can also test insulin levels and to see if they're elevated or just non-existent. And so that can help distinguish also between type 1 and type 2 diabetes. There are other types of diabetes worth mentioning. Some of them are secondary. So there's some that can be due to genetic defects, like we looked at in hereditary hemochromatosis, both in the blood and the liver chapter. So because of the iron accumulation, it damages the liver and it can lead to diabetes. And hormone diseases such as Cushing's can cause diabetes because cortisol raises glucose. Also patients that are on cortisone, that can raise their glucose levels, and you can think that they're diabetic when actually it's because of their glucocorticoids that they're on. And then, of course, we have gestational diabetes mellitus, which is a diabetes that occurs during pregnancy. It is more similar to type 2 diabetes, and the patient is at a greater risk of developing type 2 diabetes later on after the pregnancy has resolved and the baby's been born. For gestational diabetes, they often do a glucose tolerance test, and they're looking for fasting glucose levels above 95. The 1-hour glucose above 180 and 2-hour above 155 milligrams per DL. Okay, so if you have an overweight male that's 40 years old, seen an ED with chest pains, he says he's not diabetic, but his glucose is elevated at 453. Do you think he has diabetes? Yes or no? And so do you think he has type 1 or type 2? So based on this information, because he's overweight 40 and he's old enough to have chest pain and stuff, I would venture towards type 2 diabetes. And he's having the heart issues, which are a complication of type 2 diabetes. And they're also a complication of type 1, but they're definitely a complication of type 2. Okay, so one complication of diabetes can be hypoglycemia, which is really weird. So it's like a blood sugar that's too low instead of being too high. And so any plasma glucose less than 55 is considered hypoglycemia. And this can be the result of insulin injections. It can also be the result of taking some of the oral meds but then not eating or skipping breakfast. So there are two types of symptoms that the patient will have, some are neurogenic and some are glycopenic. So the neurogenic symptoms are going to be tachycardia, palpitations, diaphoresis, which is cold sweats, tremors, pallor, and anxiety. So they'll be really nervous and stuff. The glycopenic symptoms are going to be headache, dizziness, irritability, fatigue, poor judgment, confusion, visual changes, hunger, seizures, and coma. It's very possible that they may appear to be drunk to somebody, and when they could have had zero alcohol and just be in a hypoglycemic state. So severe hypoglycemia can lead to death. So it's something that needs to be intervened. There are different types of glucose solutions that can be given, like put into the cheek. And obviously one can do a quick finger stick glucose to see what's going on with the patient. So normally the brain does need glucose to function. You can train the brain to use ketones on some of the fat diets and stuff, the ketogenic diets, but it takes a few weeks, so it's not something they can just do overnight. But either way, hypoglycemia can be life-threatening, and can definitely be a complication of having too much insulin or taking some of those glucose-lowering medications without having adequate food intake. So next complications can be diabetic ketoacidosis. It's a life-threatening condition that is most common in type 1 diabetic patients. So again, as we saw, low insulin will lead to the gluconeogenesis and the ketogenesis, because the patients are, if there's no insulin, they cannot they cannot use the glucose, and so the cells think that there's no glucose, so the liver's gonna make more from non-glucose sources, and then the ketogenesis, because it's going to alternatively burn fat as fuel until it can get glucose in. So the insulin deficiency leads to enhanced lipolysis, so breaking down of the fats, which increases the free fatty acids that are delivered to the liver, and these, as they are metabolized, lead to the production of acetone or ketones, so also known as ketones. Insulin deficiency will also lead to an excessive glucagon. This is, again, because the cells are perceiving that there's no glucose because it's not getting into the cells. And this excess then alters the hepatic metabolism, which leads to a further conversion of free fatty acids into acetoacetic and beta-hydrobutyric acid, which are your ketones. And this condition has a rapid evolution, often takes less than 24 hours for a patient to go from normal into, or like controlled diabetic into DKA. And it has to be treated quickly. The result is a metabolic acidosis, because ketones are acidic, and so you'll have a drop in pH, a drop in bicarb, and increasing ketones and blood glucose. So a little bit, again, a diagram on the development of ketoacidosis. You get decreased insulin secretion, or there's, again, an increase in insulin-resistant cells. So the problem is here, no insulin, or the patient hasn't taken insulin for some reason. That means no glucose transported to the cells, which then is going to lead to hunger, because your cells are signaling you that the patient that they are starving because there's no glucose inside the cells. But we know the glucose is all in the blood, so you have hyperglycemia there, which then leads to glycosuria, that high sugar spills over into the urine, which then leads to polyuria, where they're passing a lot of really dilute urine trying to flush all this glucose out, which then leads to dehydration and leads to thirst. So these are already some of the symptoms here: polyphagia, polydipsia, polyuria here. And of course, this is also going to lead to an electrolyte imbalance, because the electrolytes are being lost in urine with the glucose as it's being flushed, as the water is flushed, trying to flush all that out. Okay, so you got that, and then you also have, because there's no glucose in the cells, glycogenolysis, so the glycogen is broken down, and gluconeogenesis, so everything is thrown into the bloodstream, that's glucose trying to get to the cells, so that leads to hyperglycemia. And then in the meantime, it's also going to break down the fats, which are going to lead to the ketone bodies, which is going to lead to ketoacidosis and ketonuria. So you'll have positive ketones in your urine dipstick and positive ketones in the serum, and that leads to acidosis. So there you go. That's a recap of diabetic ketoacidosis. The other complication, which is this one, continuing on diabetic ketoacidosis, the symptoms that you will see in diabetic ketoacidosis are going to be polyuria, dehydration, small respirations, which are rapid, deep, labored breathing, which are typical, again, of metabolic acidosis, dizziness when standing, central nervous system depression, anorexia, nausea, vomiting, abdominal pain, and thirst. The lab results are going to be an elevated plasma glucose above 250, and oftentimes way higher than that. You will see decreased sodium, phosphorus, magnesium, a decreased bicarbs, should be less than 18, and a decreased pH, which is less than 7.30. Very low potassium, a positive plasma and urine ketones, and an increase in ion gap because it's increase in ion gap metabolic acidosis. Okay, so that's what you expect there. Now the other complication, which I was trying to get ahead of myself here, which is hyperosmolar hyperglycemic nonketotic syndrome, which is a more common complication of type 2 diabetic patients. And since we have more type 2 diabetic patients in the population, it's important to understand this one. So this is, if you will, an aggravation of the diabetes process, but it's usually caused by infections or medications the patient's on, or non-compliance. Again, this is a more common complication of type 2 diabetic patients. So the insulin that is present and does get into the, on the receptors and allow some of the glucose into the cells does prevent excess fat metabolism. But the glucose levels will be extremely high, and you're going to get, because of these extremely high blood glucose levels, there's going to be a massive loss of water and dehydration. Mortality is high with this complication. They can have glucose levels above 750. The serum osmolality is going to be increased, but unlike diabetic ketoacidosis, the pH is normal, the bicarb is normal, there's no ketones, and that's why it's in non-ketotic syndrome. So there's no acidosis, no ketones, but there's just a severe dehydration that is life-threatening. So some of the complications of diabetes, again, stroke, cataracts, retinal microaneurysms, hemorrhage, and exudates, coronary atherosclerosis, glomerulosclerosis, occlusive atherosclerosis, infection, gangrenes, and neuropathy are all complications, common complications and side effects of having diabetes, especially if it's not well managed. So a little bit on the measurement of glucose. There's different ways that glucose can be measured. It can be measured in blood, serum, plasma, urine, and body fluids. So blood meaning whole blood. So you do have to know that whole blood readings are going to be 10 to 12% less than the serum readings because of the presence of red cells in the sample. Normally you want to do, if you do blood glucose analysis and you're doing the analysis on serum or plasma, you want to separate the serum or plasma from the cells because what happens is the red cells are continuing to use glucose or glycolysis for energy, and so as the serum or plasma sits on the cells, it will lower the glucose by 5 to 7% per hour. So it's important to spin these samples down right away and either use a gel separator to separate those the serum or plasma from the cells, or you can use a gray top, which is a sodium fluoride tube, because it inhibits glycolysis, and then that one can be held as whole blood to be used for later if it needs to be sent out or anything. So AccuCheck finger sticks are usually done on whole blood, obviously. So one question here, if your fasting blood glucose is 102, what does it mean? Are you diabetic? Are you not diabetic? It's higher than normal because 100 is the top of normal. So what do you think? If you're not sure, go back. We talked about it a little bit earlier. So let's keep going with the glucose methodologies. So hexokinase is the gold standard in glucose testing. It has higher specificity. The hexokinase method, however, is more expensive. It uses, it's a coupled enzyme assay, uses a hexokinase enzyme. That's where the name of the test comes from. And It converts NAD to NADH or NADP to NADPH, and that's what's being measured. And the amount of NADPH or NADH is produced is proportional to the amount of glucose. These are the reactions. So glucose plus ATP, so the glucose in the sample plus ATP in the reagent, and the hexokinase in the reagent leads to the production of glucose 6-phosphate plus ADP. Glucose 6-phosphate then can react with another enzyme, which is G6PD dehydrogenase, and the NAD or NADP in the reagent is producing NADPH or NADH, and this is what is being measured, and also produces 6-phosphogluconate. But this is what's being measured right here. So for every molecule of glucose, you have one of these being produced. This causes a color change, which can be measured spectrophotometrically. So there you go. That's the hexokinase method. The glucose oxidase method is a different coupled enzyme assay. It uses the glucose oxidase enzyme, which is where it gets its name. It is cheaper, so a lot of labs use the glucose oxidase, but high levels of bilirubin, uric acid, and ascorbic acid, which is vitamin C, can contribute to decreased readings, so it can interfere with the assay. And this one, glucose plus water and oxygen reacts with glucose oxidase to give you gluconic acid and hydrogen peroxide. The hydrogen peroxide then is going to react with this O-dianoside with a peroxidase enzyme. You get oxidase O-dianoside, which causes a color change, which can be measured and is proportional to the glucose concentration. A little bit on glycosylated hemoglobins. So you're constantly making hemoglobin as part of your red cells, and what happens with this glycosylation is that molecules of sugar can get stuck on the hemoglobin, and once they're stuck on there, they're not coming off. And the neat thing there is that this process does not require an enzyme, meaning there's nothing, the only thing that drives how much the hemoglobin gets tagged with sugar molecules, with glucose molecules on it, is how much glucose is present in the blood. Incidentally, glucose sticks to other proteins too. We just happen to choose to read it on hemoglobin. It is also called hemoglobin A1C. It is reflective of an average of 2 to 4 months average glucose. This is because that covers about the lifespan of a red cell, which is 120 days. The gold standard method for A1C measurement is going to be high-performance liquid chromatography, but there are a lot of immunoassays and colorimetric assays that are available on the large analyzers. The methods should be traceable, and any patient that have conditions that affect red cell survival cannot be monitored this way. So, for example, if they were a sickle cell patient and they have a higher turnover of red cells and stuff, then they can't be monitored that way because their red cell lifespan is shorter. Fructosamine is another way to assess this. This one actually looks more at a 3 to 6 week glucose measure. But so if a patient cannot be monitored via A1C, they could be monitored by fructosamine. But if a patient has altered serum protein levels, so low protein levels, hemolysis, lipemia, uremia, uricemia, or heparin presence, and all these can interfere with the reading of fructosamine. All right, next little question. If your patient had an elevated A1C but a normal glucose, do you think their diabetes is controlled? Is that yes or no? So think about it this way in the form of patient behavior. It could be that they're really misbehaving and eating they're being non-compliant, or at least non-compliant with their diet, and they know they're coming up for their checkup, and so they'll behave for a week before the checkup and to get normal glucose readings, but when you draw their A1C, the A1C is going to reflect what they've been doing for months. So if they have an elevated A1C, they're essentially not being compliant, or they're not managing their diabetes well. Say a little bit on the oral glucose tolerance test here. It is mostly used in gestational diabetes screening. It used to be a diagnostic tool, but for regular diabetes, but it's just not done anymore because there's just better ways for us to do it. But the procedure is the patient should come in fasting, and you give them a loading dose of about 100 grams of glucose. They have to drink this really sweet drink. Before they get the loading dose, you do draw a fasting sample of glucose, and they drink the glucose drink, and then the blood has to be drawn at 30 minutes, 1 hour, 2 hours, and you can go 3 hours even. And so most of them are 3 hours in length. And so if a patient has a normal glucose metabolism within 2 hours post a glucose load, their blood sugar should go back to normal. And certainly about 3 hours, it should be completely normal. If the patient has diabetes or gestational diabetes, that after that load is going to be elevated, and it will stay elevated for 2 to 3 hours and will not return to normal until many hours later. Again, so currently done for gestational diabetes. That's pretty much its only application. And then as we finish up the pancreas, let's just mention cystic fibrosis. It's a multi-organ disease that involves the lung, liver, pancreas, and the GI system. Many patients with cystic fibrosis have pancreatic insufficiency, and so they need to be supplemented with the digestive enzymes to properly break down their food. And we're going to leave it at that. They can suffer from malabsorption and maldigestion. Anybody that has issues with their pancreas, as in with the digestive portion of the pancreas, with it producing the proper amount of enzymes like the amylase and lipase and all the trypsinases, all the trypsin and the ones that break down protein. So you can have problems with maldigestion and then also malabsorption. So this is all related to the inability of the body to absorb nutrients. So malabsorption is usually due to inflammatory bowel diseases. So this is the food is being properly broken down by the enzymes, but it's not being absorbed. It's not crossing over into the bloodstream. And so it usually happens in the distal part of the digestive tract, and there's a failure to absorb the foods that have been properly broken down. Maldigestion, though, involves the pancreas, and it happens in the proximal part of the digestive tract, and it's the inability to break down food because the pancreas is not producing adequate amount of the enzymes. And that can be remedied, as we just mentioned, with cystic fibrosis, with supplementing with digestive enzymes. The signs and symptoms of these are going to be anorexia, weight loss, so no appetite, basically, weight loss, fatigue, shortness of breath, edema, weakness, tetany, dehydration, nutritional deficiency, abdominal discomfort and distensions, feeling bloated, flatulence, which is gas, the gut rumbling a lot, having watery diarrhea, and having steatorrhea, which is due to the presence of fat in stool, and you get loose, bulky, offensive, really stinky stools. They're light-colored and greasy, and they're difficult to flush. So those would definitely be worth investigating. And how do we diagnose pancreatic insufficiency? We can do screening tests like the CBC, ferritin, folate, B12, which assess basically your ability to even get those, to get nutrients, macronutrients in. Chemistry panel like a CMP, you can look at that, especially see if there's enough albumin and total protein being made. But specifically, you can do a fecal fat, so looking for the presence of fat in stool, meaning that it's not being properly broken down and absorbed. Look for pancreatic elastase. These are the two most commonly done. You can also do the secretin cholecystokinin test. Look for trypsin in stool and trypsinogen in blood, and chymotrypsin on stool. So again, these are enzymes that would break down proteins, and if they are not there, then there's an insufficiency. Okay, so and the same thing with pancreatic elastase. If it's not there, if there's not enough of it, then there's an insufficiency. or if there's too much fecal fat. If there's fecal fat present, there's an insufficiency. So there you go. And that wraps it up for our pancreas chapter. If you have any questions, if you're in my class, you can put them in your pod or email them to me. If you're on YouTube, you're welcome to drop them in comments, and I'll try to answer them. Thank you.